Hi, everyone. It is such a great privilege to be here today for this special occasion. Today we celebrate Professor Gerry Evers-Kiebooms. It's very difficult to summarize Gerry's career in just a few minutes, as she has contributed so much to our field. With a background in psychology and an interest in genetics, Gerry's research exploring the psychological aspects of genetic counseling and genetic testing was, when she started her career, pioneering. She has since worked for several decades to promote high-quality research in genetic counseling and has made efforts to design a framework to evaluate the benefits of genetic counseling for patients and families. Gerry established and developed the psychosocial genetics unit in Leuven, and that gave her a great platform to bring her contribution to clinical practice and research, especially in the context of predictive testing for late onset conditions. Gerry's list of professional memberships and roles on external bodies is impressive, and her publication record is equally extraordinary. So it is no surprise that Gerry has been an inspiration for so many in our field. And I am delighted so many of us are here today, even if it's in a virtual capacity, to celebrate Gerry's work. It's a great honor to award Gerry with the LPAG 2021 awards, and a treat for all of us here today to listen to her lecture. Gerry will be unable to take questions at the end of her presentation, but I will be very happy to pass on any messages you might have. So please feel free to write them down in the Q&A box, and I will collect them on our behalf and pass them on to Gerry. But of course, if you would like to get in touch with her yourself, you're very, very welcome to. After Gerry's presentation, I know Alex would like to say a few words and formally awards the LPAG award to Gerry. But before we do that, without any further ado, it is our pleasure to invite you all to listen to Gerry's awards lecture.
Dear participants of the European Conference, receiving the LPAG award is a great honor for me. I'm particularly pleased that it's an award of the European Society of Human Genetics because of the relation that I feel with the society. Over the years, I attended more than 30 conferences. As a psychologist, I'm happy that I could play a role in the society. For many years, I was the co-chair of the MPAC meetings and a member of the Interdisciplinary Public and Professional Policy Committee, as well as a member of the board. All this offered an excellent opportunity to establish closer relations and collaborations with many colleagues in Europe. It also inspired me on activities in the Center for Human Genetics in Leuven. I received this award about 10 years after my active professional career. So, giving this LPAG lecture really challenged me. I hesitated some time whether and how I could and should accomplish this task. Eventually, I decided to revisit research and collaborative studies of the psychosocial genetics unit that I founded and elaborated in university hospitals in Leuven. I'll start with a short comment on time orientation. Some people are psychologically old and mainly past-oriented. Other people are psychologically adult and mainly present-oriented. Other people are psychologically young and mainly future-oriented. I have to confess that while preparing my presentation, I felt psychologically old, and that also explains that the word revisited is in the title of my presentation. Genetic risk and uncertainty are inherent to life, and we always have to keep this in mind. But most people want certainty. In the first part of my presentation, I will revisit research about psychological aspects of genetic counseling. The complex psychological reality faced by individuals at increased risk for developing genetic disease or for having offspring with genetic disease did not receive much attention before 1980. A very long time ago, I published my first paper in the context of genetics. It was a paper about the impact of genetic counseling, a review of published follow-up studies. At that time, and also in the 80s, impact was almost exclusively studied in outcome studies. In 1986, we made a first attempt to bridge the gap between professionals in genetic counseling, health psychology, and psychological decision-making during a symposium in Leuven. It was the precursor of the later European meetings on psychosocial aspects of genetics. Some years later, in 1990, we organized a meeting about psychosocial aspects of genetics in Leuven. The first chapter of the book was written by Seymour Kessler, I would say the godfather of psychology and genetic counseling in the United States at that time. He suggested to pay more attention to the process of. He hoped that process studies of genetic counseling would assess where success is achieved and where remedy is needed, and that it would lead to a more flexible, creative, and dynamic way of providing genetic counseling. In the 90s, there was an interesting study about directiveness or non-directiveness of genetic counseling. 3 measures were used, and the intriguing finding was that no significant correlations were found between the 3 measures of non-directiveness. The rated directiveness, based on transcripts of consultations, the counselee report directiveness, and the counselor reported directiveness. In fact, this is a rather strange result. Anyway, non-directive genetic counseling, tailored to the needs of the counselees, is essential to respect people's autonomy. In the second part of my presentation, I will give a personal looking back and forward on psychological aspects of predictive testing for late-onset disease. Most common diseases with onset later in life are multifactorial diseases, determined by many genes in interaction with environmental influences. Some diseases with onset later in life are determined by one gene and have an autosomal dominant transmission. If DNA analysis is performed in a person with clinical symptoms, we speak of a diagnostic test. If DNA analysis is performed in an at-risk asymptomatic person, then we speak of a predictive test. It is a complex reality. Some late-onset diseases are usually multifactorial, but there exists a monogenic subgroup. The psychological complexity of predictive testing is also a function of differences in penetrance, the percentage with a mutation who get symptoms, and the availability of preventive measures for carriers. After predictive testing for neurodegenerative diseases, there are so far no preventive measures for carriers of the mutation. After predictive testing for hereditary cancers and hereditary heart disease, preventive measures may be available for carriers of the mutation. Lifestyle changes that reduce the risk of problems, regular surveillance that leads to early diagnosis and better perspectives for treatment, preventive surgery that reduces the risk and increases life expectancy. Now we continue with predictive testing for neurodegenerative disease. Most psychological research on decision-making and impact concerns predictive testing for Huntington's disease, the first late-onset disease for which predictive testing was possible. Less psychological research regarding predictive testing for other neurodegenerative diseases. I draw the attention on interesting studies related to the higher incidence of Machado-Joseph's disease in the Isle of Flores in the Azores. Now we focus on Huntington disease, a disease with three groups of symptoms. It's a movement disorder, there are neuropsychological defects, and there are personality changes. In the genetic clinic in Leuven, much attention was paid to the development of an adequate multidisciplinary approach and testing protocol. In the late 80s, for the DNA linkage test, later for the direct DNA test. Several counseling sessions are offered in the pre-test period as well as in the post-test period. There was close contact with the Huntington Association, not only for setting up information sessions tailored upon their needs, but also for discussing the family's concerns regarding the protocol. Nowadays, this unique collaboration between families confronted with Huntington disease and professionals is continued in the European Huntington Disease Network. The motivation for testing is very important. Each applicant for predictive testing has a personal story and personal struggles with uncertainty. Getting certainty and family planning are the two major motives for predictive testing in all reports about uptake for predictive testing. The predictive test result is at the origin of certainty or uncertainty about their own future health, as well as certainty or uncertainty about the next generation. Certainty or uncertainty about their own future health depends on the number of CAG repeats. In case of 35 or less CAG repeats, one is certain that no symptoms of Huntington disease will ever appear in life. In case of 40 or more CAG repeats, there is certainty that Huntington disease will appear later in life. There is uncertainty about the exact age at onset and about the course of the disease. Certainty or uncertainty about the next generations depends on the test result of the prospective parent. When the prospective parent has 26 or less CAG repeats, it's certain that the children will be free of Huntington disease. In case of a number of CAG repeats between 27 and 39, there may be a risk for expansion during transmission to the next generation. In case of 40 or more CAG repeats, there is a risk of 50% of transmitting the Huntington mutation to the next generation. Intergenerational changes of a CAG repeat are possible because instability of the mutation. How to get certainty in the context of reproductive decision-making? Prenatal diagnosis and pre-implantation diagnosis are used by part of the couples to exclude Huntington disease in the descendant. They are both associated with a considerable psychological cost as well as with ethical problems. The intermediate allele or reduced penetrance allele may pose special problems. Free informed decision-making about prenatal diagnosis and pre-implantation genetic diagnosis should always be guaranteed by adequate counseling, preferably by a professional involved in counseling for predictive testing for Huntington disease. Now we will look at the psychological impact of the predictive test result for Huntington disease based on studies in the Psychosocial Genetics Unit in Leuven. We focus on data of questionnaires and psychological tests at 3 time points: before getting the predictive test, 1 year after communication of the test result, and 5 years later. Now I'll discuss the psychological distress 5 years post-test, and I'll start with the carriers. The means of the psychological tests of carriers are within normal range. Carriers have more negative feelings about their test result. They also try to escape from negative consequences by consciously avoiding Huntington disease-related situations and thoughts. For some non-carriers, there is a personal adaptation process in the first period after testing. They may feel a need for rebalancing the relationship with partner and relatives. Some of them also experience survivor guilt because they are escaped while other relatives still are at risk or even had a bad predictive test result. Some partners of carriers report more distress and more pessimistic about the future as compared to carriers. They tend to adopt more passive, awaiting coping strategies and hesitate to seek social support and help. This figure presents result-specific emotions 5 years after testing. The mean scores of carriers and non-carriers and their partners on the health orientation scale are given in this slide. The more you go to the left, the less negative are the emotions. The more to the right, the more positive the emotions. As you can see, carriers have more negative emotions than non-carriers. They are more to the left of the figure. If we look at carriers and partners, we see that partners of carriers have more negative feelings than carriers themselves. And many of these differences are highly significant. Our findings are in line with publications from colleagues in other countries. About 10 to 25% of tested persons report psychological problems, a period of depression, psychological burden, hopelessness about the future, worry about the children, a period of marital problems, divorce, and other. But in general, tested persons cope rather well. Many persons at risk for Huntington's disease do not apply for predictive testing for several reasons. It's likely that uptake for predictive testing will increase when there will be an opportunity for postponing disease onset or for preventing the disease. And I think there is hope for the future because of the many international collaborations and because of the development of new therapies inspired by genetic discovery. We started a European collaborative multidisciplinary study on prenatal testing involving 6 countries in 1998, and this resulted in a multidisciplinary meeting a few years later. In the proceedings, Chapter 14 was written by Peter Harper, who unfortunately passed away about half a year ago. He considered the evidence and insights from Huntington's disease as a model for other late-onset genetic disorders. Today, I will only discuss the reproductive history after predictive testing for a subgroup with family planning as a motive in the pre-test period and with a follow-up period of at least 3 years. We see that 69% of the non-carriers had at least one pregnancy in that period. 39% of the carriers had at least one pregnancy, and in 60% of these pregnancies, prenatal diagnosis was carried out. So you see that the predictive test result had a significant impact on having further pregnancies. After the European study, data collection in Leuven was continued, and the follow-up period after predictive testing lasted from 1 to 16 years. Here too, we focus on the reproduction of mutation carriers who had family planning as a motive when they applied for predictive testing. 58% of the couples had pregnancies with prenatal diagnosis or pre-implantation genetic diagnosis. 35% of the couples had no children. 7% of the couples were undecided. Several participants of the European study and the multidisciplinary meeting continued their collaboration within the European Huntington Disease Research Network and its working group Genetic Counseling and Genetic Testing, founded in 2008. This resulted in a paper with recommendations and suggestions for good clinical practice in the reproductive care for Huntington disease families and for families with other neurodegenerative late-onset disease. Now I'll give a few closing comments on 3 topics: predictive testing for late-onset disease, direct-to-consumer testing, and NIPT. First, the closing comment on predictive testing for late-onset disease without availability of preventive measures. It depends on many factors whether knowing is preferred to not knowing. Person-related characteristics, the specific familial context and family dynamics, the cultural societal context, and also the organization of healthcare and the legislation. A prudential approach and adequate pre-test and post-test counseling is very important for facilitating decision-making as well as for supporting testees to integrate the test result in their life. Now a few personal comments about direct-to-consumer testing for late-onset diseases. First of all, persons' capacities to understand probabilities are often overestimated, and the risk of information overload is often underestimated. Insights from cognitive psychology about risk perception and decision-making should receive more. The expectations about the potential for behavior change are too high. This is based on findings in health psychology in other contexts. It's very difficult to provide adequate counseling. My opinion is that public education about genetic risk and genetic testing and its implications is essential for informed decision-making and for having realistic expectations. expectations. Last but not least, a few comments on non-invasive prenatal diagnosis, NIPT. Some prospective parents, faced with a decision to have or not have NIPT, receive only very limited counseling about the scope and implications of the test. This is an obstacle to informed decision-making, and, moreover, it may be at the origin of substantial psychological stress when an anomaly is detected that was not sufficiently explained before the test. Many pregnant women are not satisfied with the counseling that is offered by the clinician. The composition of the standard panel used for NIPT has far-reaching consequences and should therefore be the subject of an ethical debate. Balanced genetic education of the public about NIPT is essential to ensure that pregnant women and their partner will be better prepared for the offer of NIPT and for making an informed choice. Adequate counseling before the offer of NIPT and extensive genetic counseling after the detection of an anomaly is of the utmost importance. Thank you for your attention.
Great opportunity to revisit not only Gerry's career and contributions, but also to some extent review and consider some of our professional roots and identity. I'm delighted to have with us Professor Alexandre Raymond, the chair of the Scientific Program Committee, who is formally awarding Gerry with the LPAC 2020 Awards on behalf of the ESHG. Thank you, Alex, for being with us.
We moved from having an MPAC meeting every other year to encompassing a full ethical, legal, and psychological track, so the so-called LPAC track in the ASG annual conference, and this since 2018. I think that in doing so, we really embraced all facets of human genetics. And it's important to say that we also moved even further by establishing this LPAC award to recognize what I would call European beacons of the specialty. And Gerry Evers-Kiebooms has been an inspiration for many. It is time for the European Society of Human Genetics to honor her scientific legacy, and I have the privilege to present her with the LPAC Award 2021. Congratulations, Gerry. All the best.
If only we could be together and give her a standing ovation and applause. Thank you very much. As you know, and I mentioned earlier, Gerry was unable to join us today, unfortunately. But if you have any questions, any comments for Gerry, please write them down in the Q&A box, and I would be very happy to pass them on to Gerry.
Of course, feel free to send her congratulations and directly also, even if it's not via Ramona or myself.
So I think that's all for now, I guess. Thank you all very much for joining us today, and looking forward to seeing everyone online later for the rest of the conference.